Hi, welcome back to IU Radiology Case of the Day. My name is Nick Kuntz, and I'm a neuroradiologist and head and neck imager at Indiana University School of Medicine, and I'm back with another interesting head and neck radiology case of the day. I want to start by specifying that all of the content found within this lecture has been completely de-identified in order to protect patient privacy. Okay, so this is a case of a patient who presented with a neck mass. And this neck mass had been present for a while, had been growing slowly over time. We have three images to look at. The image on the left is an axial T1 weighted image. This is a pre-contrast T1 weighted image. The image in the middle is an axial T2 weighted fat saturated image. And the image on the right is a lateral digital subtraction angiogram. So it's from a common carotid artery injection. So take a look at the three images. Slow growing mass. Try to piece this all together. Okay, I have a whole slew of questions for this case. So first of all, what are the findings? Second, what's the space of origin of the lesion that we're seeing on the images that were provided? There's a couple of signs here, classic radiology signs. One is associated with the MRI, the other is associated with the angiogram. What are the names of those signs? And then lastly, what's our diagnosis? So let's start by looking at the images. First up is the axial T1 weighted image. Again, this is a non-fat saturated pre-contrast T1. There are a lot of places that like to fat saturate the pre-contrast T1 weighted imaging. I think that's in general quite a mistake. We like to do ours here without fat saturation because you want to see that fat. Where you see the fat on head and neck cases is really critical for being able to figure out where tumors are involving, get a better sense of the anatomy. So use the fat to your advantage. Okay, enough of that soapbox. So we have a circumscribed left suprahyoid neck mass, the arrow is pointing at it, and this is centered in the carotid space. That's a key feature that you want to pick up on. Whenever you see a mass in the neck, figure out the space of origin, because if you can figure out the space of origin, that will dramatically narrow down your differential diagnosis. So if you look carefully at this mass, you can see that it has some speckled foci of intrinsic bright T1 signal intensity. And it's been referred to as the so-called salt, the T1 bright salt within these particular masses. And you can see it's a bit subtle, but you can see some areas of intrinsic bright T1 signal intensity where these arrows are pointing. Now I will say that this is a finding that when you see it, great, but you don't always find this. In fact, it's probably a minority of patients that have nice T1 bright salt. Next up is our T2 weighted image. And this is nice because we can see those flow voids of the internal carotid artery and external carotid artery. And you can see here we have this characteristic splaying of the ICA and the ECA. So in this case, the ICA gets pushed posterolateral, the ECA gets pushed anteromedial as such. So you can see those are getting splayed apart. That's a very characteristic finding here. The other thing that you'll see is when you look carefully, particularly at the periphery of this mass, we can see these T2 dark or hypo-intense foci, largely at the periphery. These are the so-called T2 dark pepper of this particular mass. So we have the salt on the T1 weighted imaging, we have the pepper on the T2 weighted imaging. We see the pepper a whole lot more frequently than we do the salt. We'll talk about what that salt and what that pepper mean here in just a few slides. The last image to look at is this lateral DSA, and you can see this is a very vascular mass. We can see the tumor blush during this phase of the injection. And if you were to put the center of this mass, you'd center it right at the carotid bifurcation, and we have that characteristic splaying of the ICA and the ECA getting pushed apart by this mass that's centered right at the carotid bifurcation within the carotid space. This has been referred to as the liar sign because it looks like these antique harps, the way that the vessels get splayed apart. So put it all together. We have a carotid space mass that's been slow growing. It's got the salt and pepper on MRI. It has the liar sign on the digital subtraction angiogram. We can see it's centered right at the carotid bifurcation. It's a very classic case of carotid body tumor. So this sometimes is referred to as a glomus caroticum paraganglioma. And these are vascular, oftentimes pulsatile, slow-growing carotid space masses. And these are comprised of chemoreceptor cells that come from the neural crest. And they're typically going to be unilateral and solitary, but it's important to keep in mind that in a minority, still a small minority, but a significant minority, these may be multiple, these may be bilateral. There are other characteristic sites within the head and neck where we look for paragangliomas. We'll talk more about those in subsequent cases of the day. These carotid body tumors can be distinguished by the characteristic splaying of the ICA and the ECA. We talked about that Lyre sign. It's important to keep in mind for those that may do endovascular work that the typical arterial feeder of these is the ascending pharyngeal artery. They can have contributions from other arteries, but the ascending pharyngeal is an important artery to keep in mind because these oftentimes need embolization prior to surgical resection in order to prevent blood loss. These have a characteristic salt and pepper appearance on MRI with that T1 bright salt that is thought to represent subacute hemorrhage. It's seen less frequently than the T2 dark pepper, which are those high velocity flow voids that oftentimes are going to be seen at the periphery of the mass. There are a few syndromic associations to know about, particularly those of you that are studying for boards or other shelf exams. It's important to keep in mind that yes, in fact, there are multiple syndromes that are associated with carotid body tumors. Most commonly, these are going to be patients that have familial paraganglioma syndromes. Those have to do with SDH gene mutations or succinate dehydrogenase gene mutations. But you can also see these in the setting of multiple endocrine neoplasia type 2, von Hippel-Lindau, and neurofibromatosis type 1. So NF1, not NF2, NF1. There's a nice paper that was written by the folks at the University of Michigan a few years back looking at vascular lesions of the head and neck. So I would highly recommend all the residents and fellows out there take a look at this paper. It's a quick read, really nice images. So let's wrap this up. This was a case of a carotid body tumor. The key imaging features are on MRI, we had that salt and pepper sign with the T1 bright salt, likely representing subacute hemorrhage, and the T2 dark pepper representing those high velocity flow voids, commonly at the periphery of the mass. And again, we see the T2 dark pepper much more commonly than we see the T1 bright salt. And again, these are very vascular tumors. These will avidly enhance on all modalities. So regardless of whether you're doing CT, MRI, whether you incidentally pick one of these up on a CTA or an MRA, or if it's something caught on an angiogram, conventional angiogram, these are vascular tumors that will enhance very avidly. You also look for that Lyre sign with the characteristic splaying of the ICA and the ECA. Now I want to stress once again, there is a pitfall here, and it's to avoid the satisfaction of search. So when you see one of these, the spidey senses really need to be tingling. You need to be looking for other ones, because in a minority, but a significant minority, 10% or so, maybe a little bit less than that, you'll find either multiple paragangliomas within the head and neck, or you'll find potentially bilateral paragangliomas. So if you see it on one side, really scour the other side as well. And we'll talk more about the characteristic locations of other paragangliomas in the head and neck in a following case of the day. So as always, thanks for tuning in to IU Radiology Case of the Day. You can follow along on Twitter at NAKuntz, and I would invite you to check out our complete collection of Case of the Day materials that can be found at radtf.iuhealth.org/COTD. Thanks so much.